Started. Welcome to our Ethics Grand Rounds from University of Colorado Hospital and the Center for Bioethics and Humanities. I am Julie Swaney, and I am one of the co-chairs of the Ethics Committee at University of Colorado Hospital, and am going to be moderating today. Very thrilled to have two of our presenters today. And if you will put your questions or comments in the chat along the way, we will do our very best to get to those. I have the privilege of introducing our speakers, both of whom will be participating in a conversation together. Dr. Huntington Potter is the founder and director of the University of Colorado Alzheimer's and Cognition Center. He's a professor of neurology and a member of the Linda Cernick Institute for Down Syndrome. He studied and researched and taught at Harvard for 30 years. He is a prolific author, a member of the National Academy of Inventors, and his electron micrographs of DNA are on permanent exhibit in the Smithsonian Institute. So thrilled to have him with us. He is going to be interviewed by and be in conversation with our esteemed colleague, Dr. Matthew Wynia. Dr. Wynia is the director for the Center for Bioethics and Humanities and is a professor at the University of Colorado School of Medicine. So they are going to be having a conversation about ethical issues in Alzheimer's research and treatment. So I will turn this over to the two of you. Thank you so much. We're really looking forward to this time together. Again, if folks would put their comments or questions in the chat, we will get to those as we can. Thank you very much.
Thank you, Julie. And Dr. Potter, it's great to talk to you again. Yes, it's been a pandemic.
COVID interrupted a few things.
A couple things interrupted the flow we had going. So I want to let everyone know this is in some ways a reprise of an event that we did before the pandemic, where we sat in a community setting live with a bunch of community members and talked about some of the ethical issues that arose. And that, if I recall correctly, the way that came about was because you and I ended up talking one day about a drug that was already on the market and in somewhat short supply, and data were about to come out that suggested that drug might be effective as an early treatment for Alzheimer's disease. And the concern was that there might be a run on that drug from people seeking to use it off-label, and that might actually hinder availability of that drug for people who really needed it for purposes for which it was already approved. And I have to say that scenario has come up a half a dozen times now during the pandemic with a variety of different drugs with better and worse, justification. And then just this last week, I saw a piece that I want to ask you about. There is I don't know if drug is the right thing, a combination called AXS-05 that apparently might reduce agitation in patients with Alzheimer's disease. And the results on this came back recently, I guess. The FDA is considering granting it breakthrough status. But when I read the article, you realize this novel drug is dextromethorphan and Wellbutrin. And those are drugs that are easily available already. And so it just reminded me, like the week before we were supposed to have this conversation, the same kind of issue came up that prompted our original conversation. And I wonder, what should we know about this combination of dextromethorphan and Wellbutrin? How promising is that, in your view, if you're familiar with that line of research? And do we need to worry about this? Like, is there going to be a run on dextromethorphan now?
Well, that's an interesting question because the problem of agitation in people with Alzheimer's disease is a serious problem, both at home and in nursing home settings. And there are a number of drugs that physicians use to try to combat that agitation. The new data do look promising for this combination of drugs, but the work isn't completed yet. And breakthrough designation does not, necessarily mean that the FDA is going to approve the combination in the end after it looks at all of the data. But you bring up a very good point, which is that these are relatively understood and well tolerated drugs for many years. And certainly in the case of a physician who wants to bring that on as an additional treatment or a replacement treatment for agitation, they're essentially free to do that, essentially using the two drugs separately. But it remains to be seen whether there's going to be any concern about a run on the drugs, since they are pretty widely available. I don't think at least that problem will be present in this new scenario where people are excited about this as a potential treatment for this very special aspect of Alzheimer's disease, namely agitation. But there are no evidence that these drugs have anything to do beneficially with the basic underlying Alzheimer's disease.
I do want to get to the developments with aducanumab and lecanemab and so on. But before we leave this, I am curious. I think the last time we spoke, I didn't yet have a family member with Alzheimer's disease, and now I do. And so I'm absolutely in sync with your comment about agitation being a very serious problem. And I'm wondering, without asking you, would you prescribe this off-label? Do you think this is going to end up widely prescribed off-label, even in advance of the FDA getting through its process of deciding whether it's a breakthrough therapy?
Well, not being a physician, I really can't comment on the potential for physicians to prescribe this off-label. As you know, I'm a researcher. We do clinical research and basic research and everything in between. But when it comes to patient-physician interactions, those are private and very individual, in the sense that each patient is different, and the physician has to make a decision with the family and with the patient as to what is the best way forward.
Yeah. And then my last quick question on this, is there a chance that we're just seeing the effects of Wellbutrin alone? What's the dextromethorphan? What's the additive benefit of putting a cough suppressant on top of an antidepressant with some anxiolytic properties?
Well, all drugs have multiple effects. The drug may have been designed as a cough suppressant in various different settings, but it will have other side effects, as people who have taken it can attest to. And it's the combination of those with the other drug that gave the idea that maybe this combination would be effective. I haven't seen the published data yet to see whether each one separately was tested against the combination, or whether the combination was tested in the absence of anything. And that would be something to look up, which I don't remember right now.
Yeah, I think if I recall, and again, I am a novice to this, but I think they have not yet tested it against Wellbutrin alone. And I was just wondering if there's a reason why dextromethorphan would boost the Wellbutrin effects, because it seems like Wellbutrin might have some benefits on its own.
Yes, and of course, this could be a case of not having enough money to do everything, and so they wanted to, hit a home run and figure that the combination was likely to be better. Right.
Before we jump into aducanumab, which you knew was going to be on the docket, I'm sure. Can you give the audience a brief rundown on the on the underlying hypothesis below aducanumab and lecanemab. What is the amyloid hypothesis? Why is it important? What has it brought us?
Well, it's been decades, of course, since the amyloid hypothesis was first sort of composed. And the reason that it was is because there are certain families that have inherited Alzheimer's disease due to a mutation in one of 3 genes, one of which is the amyloid precursor protein gene itself, which is on chromosome 21, and then the 2 presenilin genes, whose function is to code for a protein that makes the A beta peptide out of the amyloid precursor protein. Now, because these individual families and the people who carry that mutation show the same cognitive problems and the same pathology in the brain, namely amyloid deposits and neurofibrillary tangles that characterize all Alzheimer's disease.
Mm-hmm.
It's been reasonably interpreted to indicate that all Alzheimer's disease has these features. And when you take one of these mutant proteins, genes coding for these proteins, and introduce them into mice, then the mice get Alzheimer's disease, which they normally don't do. So there was a lot of pathological, biochemical, and behavioral data to say that the very first step in Alzheimer's disease is the generation of too much A beta peptide and its aggregation with itself to make these amyloid deposits. Therefore, it was very reasonable that we should try to get rid of the amyloid deposits. They're the first step. If we could stop them from forming or get rid of them after they formed, then this should be a very reasonable treatment. And it worked great in the mice. So aducanumab is the first of these monoclonal antibodies, which means that it's a very special antibody that's been designed and generated in large amounts that attacks the amyloid deposit. And lecanemab is a similar monoclonal antibody. So there's no question that these drugs, both in their initial testing in mice and now in humans, are very effective at getting rid of the amyloid deposits. Very effective, and in a fairly short period of time. The argument has been, and we'll discuss this in as much detail as you like, that when the clinical trials were completed in Alzheimer's patients, instead of making them normal or better as the drugs did in mice, the only thing that happened was that the decline was slowed. Now, this is a big advantage for Alzheimer's patients and their families, no question about it. But it wasn't the magic bullet that everybody hoped they would be. And that has opened up the minds of scientists all over the world to think about new approaches for Alzheimer's disease that could be used either independently or possibly together with these new drugs, aducanumab and lecanemab.
So let's talk aducanumab first, just because there are some interesting policy issues that have arisen there that do have ethical implications for patients and their families. And I guess maybe before we get to coverage policy, can you say a little more about what was seen in the clinical trials in terms of the extent of benefit, or and how that benefit is measured? I guess one of the questions that I think is still sort of in the air for me is, were the benefits that have been seen things that I would notice if they happened to my loved one with Alzheimer's disease, or were they more things that you can detect if you go looking for them, but I would have never noticed it myself?
Yes, that's a good question, and always the problem with the FDA approving drugs. If there's not an obvious clinical benefit for the patient and the family, but there is a benefit in a large trial where you're comparing treated and untreated individuals, Is this a personal benefit, or is it a societal benefit? And exactly what the benefit is in the individual case of slowing the course of the disease, which is definitely a benefit, versus, as you were beginning to bring up, I'm sure, the side effects. Every drug has side effects, but both of these, and especially aducanumab, have two side effects, which is that there can be detected bleeding into the brain, little microhemorrhages, and swelling of the brain, what we call edema. And those are almost always not clinically relevant, but they can be detected by a brain scan, and they are worrisome because they could go on, if they continue to arise and get worse, to generating a clinical problem for the patient. So as with every drug, you have to balance the benefit and the risk. And what the FDA decided in the end with aducanumab was that this balance was acceptable, and that the removal of amyloid gave a very good a priori argument that the drug in the end would be useful. But their approval came, as you know, and many people in our audience know, with some controversy, and we can discuss that in greater detail.
Yeah, let's. I'd love to hear your thoughts on the controversy. I guess my less educated version of this from the Washington Post and the New York Times was the trials did not show a ton of clinical benefit. They were mixed results, but the decrease in amyloid plaques was apparent, and so it was approved based on this sort of marker that doesn't necessarily correlate in the end with clinical benefit. And because this is also going to get us to the lecanemab results, which did seem to have some clinical benefit. And I guess I'm curious how, correct what I just said, or is that a fair assessment of what the results were? And how much of an improvement are the lecanemab data in terms of clinical improvement compared to the aducanumab data?
Yes, you have it exactly right. And the lecanemab trials were greatly benefited by the groundbreaking work that the aducanumab trials, forged into this virgin territory, essentially. The problem with the aducanumab trials, they were stopped early because the calculation by the statisticians looked as though they weren't going to reach their endpoint. And one of the reasons for that was that the highest dose of aducanumab also gave the highest side effects, these microhemorrhages and edema. Yeah. And so the highest dose was reduced in the particular set of Alzheimer's patients with an ApoE4 genotype, which are the most at risk, say, of developing further. What that did was to reduce the number of people who were on the highest dose, which reduced the statistical significance, and essentially the primary outcome wasn't met. But when the company and the statisticians looked backwards at all of the data, their conclusion was more positive, and that's what they presented to the FDA. And as you know, the Scientific Advisory Board for the FDA voted against approving the drug, and the FDA, because there essentially is no treatment for Alzheimer's disease, decided to go ahead on this specialized approval that they gave it. But the end result is that many physicians have been positive. I'm not a physician, but looking at the data, I think that overall they are positive, weakly positive and with caveats, but certainly better than anything that had come before. On the other hand, many physicians looked at the cost-benefit analysis They said, well, we're not going to prescribe this. And in fact, as you probably know, I think this drug is, although FDA approved, not actually carried by the University of Colorado Hospital formulary. So some people can get it if they go to their doctor. It is FDA approved, but many physicians are very hesitant to prescribe it.
And Medicare made a decision on this too, right? That was the other policy issue I recall. And I don't know where that sits now, but the initial decision, as I recall, was that they would only cover this for Medicare patients if they were in an ongoing trial. Is that still the case?
As far as I know, you have it exactly right. That is the case. And that, of course, reduces hugely the number of people who could benefit from this drug, because it would be very expensive if it weren't covered by insurance or Medicare or Medicaid. And of course, the insurance companies tend to follow Medicare and Medicaid decisions. And so the end result is that the only people who are actually getting aducanumab, to my knowledge, are those in a clinical trial or who can pay out of pocket.
And this is a significant amount out of pocket, right? What's the, again, this has changed over time, so I'm not sure where it sits now. When it first got approval, my recollection is it was exceedingly expensive, and then they cut the price in half. Can you fill us in on that?
Exactly, that's exactly right. And I don't remember the exact numbers, but is many tens of thousands, say 50,000 or so, for the prior cost, and now half of that. That, of course, has to be balanced with the fact that many people with Alzheimer's disease are in nursing homes, and the longer they stay in nursing homes, or if they're at home, the likelihood they're going into nursing homes, if that gets reduced by aducanumab treatment, then it's a very complex balance of cost versus benefit, taking into account all of the cost that the patient may accrue.
Yeah. So if we had some data suggesting people stay out of nursing homes for an extra 2 months, that feels like that makes the cost benefit assessment a little more complicated, because you have to take into account the cost of being in a nursing home. The lecanemab trial, I also want to touch on, because my understanding again is that from the New York Times, which I'm not reading today in solidarity with their reporters who are apparently on strike today. But anyways, the papers said that there was a significant benefit. And if I recall, it was something like 27% improvement on a set of tasks and so on. Is that something that I would notice if my family member got this? Would I be able to recognize, oh, it's not progressing as fast anymore, or they're actually a little better these days than they were a month ago?
I don't think you would notice either a slowing of the decline or a benefit. There weren't any good data that there was benefit. And of course, detecting decline assumes that you have a very good measure what the decline was.
The baseline, right?
The decline before you take the drug, and then somehow or other they leveled off. Very, very, very difficult measure on the individual basis. So the data of 20% improvement, that's improvement over no drug, meaning that the decline is less, was only statistically significant with very large numbers of people. So from a public health point of view, it's definitely a drug of benefit. But for the individual patient, they and their family might not notice.
That's very interesting. My, again, personal experience, but the rate of decline is not a consistent rate, right? Some days are much worse, and then other days are better, and then it seems like it gets worse for 3 weeks in a row, and then there's an improvement. So I can see your point that you might never know if you gave this drug to a patient, it might be completely impossible for any one individual to tell whether they derived any benefit from this. It's only in the context of a trial that you can see whether in the aggregate it's providing some benefit.
Exactly right. And your experience is mimicked by families and patients all over the world, that it is very variable from one day to the next and from one week to the next.
Yeah.
I've often said that if we only knew how to make the bad days into good days, we'd be able to give people an extra 5 years. And we don't know why that variation is so striking.
Right. I want to go back for a second because I found it fascinating getting ready for this talk, reading about cerebral amyloid angiopathy. And I wonder if you could say a word. So what is that? And how does that relate to these side effects of the microbleeds? And in at least a couple of cases, apparently significant bleeds, there have been a couple of deaths that, again, small numbers, so who knows if they're directly related to these trials, but at least some of the commentators have suggested they are probably related to being on these drugs.
Okay, so that's a complicated question, but it's very important, as you said, with respect to the microbleeds. So what Alzheimer discovered back in 1907 were what we now call the plaques. These are the round, sort of spherical deposits of amyloid peptide in many parts of the brain involved in cognition and memory. And those amyloid deposits, or the precursors to them, are quite toxic to nerve cells. In addition, it has since been found with better methods that the blood vessels of the brain also end up having deposits of amyloid in their vessel walls. And that's what we call cerebral amyloid angiopathy. Now, when you have that kind of abnormal deposit of protein in many diseases, actually, on the blood vessel walls, it can weaken the blood vessel walls and make them prone to breakage and bleeding. So the amyloid angiopathy is a dangerous part of Alzheimer's disease all by itself. However, the extra bleeding that comes from treating with an antibody whose job it is to get rid of those deposits is quite striking, and probably arises because these antibodies stick to the amyloid, and then they attract the phagocytes, the little Pac-Men that go around the brain and eat up things that aren't supposed to be there, to come and try to get rid of that amyloid in the blood vessels or in the plaques. And that could leave a hole. And in fact, we can see that it does leave a hole when you get rid of amyloid. So if that hole is in the middle of the brain, that's still not good. But if it's on the blood vessel wall, that could lead to the bleeding. So this side effects of microbleeds are really a natural consequence of the mechanism of these.
Yeah, I found that fascinating. I hadn't realized there are blood vessels apparently where all of the smooth muscle that lines the blood vessel has been sort of taken over by amyloid deposits. And if you remove those amyloid deposits, you so weaken the blood vessel that it can create a break.
Yes, exactly. And we certainly don't want that, especially since many people who have Alzheimer's disease also have a kind of dementia called vascular dementia, where small microbleeds into the brain caused by atherosclerosis in many cases leads to a dementia of a slightly different clinical kind, but it's still a dementia, and it's by a completely different mechanism. So if somebody has both vascular dementia and Alzheimer's disease, which is extremely, extremely common, then any kind of bleeding due to getting rid of the amyloid in the blood vessel walls and making them weaker could just add fuel to the fire. And that's, of course, a great concern. And it's also, in my view and some people's view, one of the reasons why these drugs have ended up slowing the decline rather than reversing it. Because if they're causing some harm on one side of the scale and some benefit on the other side of the scale, then the end result is probably better than nothing, but it's not what we all hoped for these drugs.
Yeah, that's a fascinating idea that you could be relieving one type of dementia, but making the other type of dementia worse. And so in aggregate, either no difference or just a marginal difference. I want to get to some of the questions that have been raised in the chat already. And at the top of the list was a pretty broad question, but it's around how your research center, how individual research protocols make decisions about when and where, how much information to share with someone who is in a study. Because of course, some of these studies are randomized, blinded. So sort of part of the design is that the participant doesn't know things. How do you think about that in terms of the rights of the research participant and the value derived from the information?
Well, the worst kind of clinical trial is one that is not blinded. And that's because both the patient and the physician and the analyzers know who got the drug and who didn't. If that were true of all trials, we wouldn't be able to conclude anything at all, because the placebo effect is very real, and bias in interpretation of very carefully designed, but still executed by humans, neuropsychological tests, it could end up adding either bias in one way or another, or at least variation, where knowing that the person came in last week or 6 months ago and was at a certain stage, and now maybe they got the drug, or if you know they got the drug, look for things that indicate some benefit. That's a really good way to ruin a trial. And any trial that isn't double-blinded will not be accepted by the FDA. So you'll be doing all this work for no good at all. So now you bring about the ethical question of the participant. Everyone knows every participant has to sign a consent form in which they're told that they don't know, and the physicians don't know, and the analysts don't know who got the drug and who got the placebo until the very end of the trial when all the data are analyzed. And therefore, we as scientists cannot tell the participants anything about the results, because it's not relevant if we don't know whether they got the drug or not. The only difference that comes up is that if something shows up either in a brain scan or a blood test or even a neuropsychological test that is very clinically relevant to that patient, then it is, of course, unethical to withhold that information. That information then is presented to the patient and their primary care physician, because they may need clinical intervention for, let's say, a side effect or something that they didn't even know they had, like a brain tumor. Of course, we would never hide that from the patient.
So essentially, you would be unblinding that person, but you'd be unblinding them both to the person and to yourself.
And they would be taken out of the trial.
They would come out of the trial. They would be unblinded. But in the sort of most blunt sense, a patient in a trial could ask you, "Am I getting the real thing or am I getting a placebo?" And your honest answer would be, "I have no idea."
Correct.
Because you actually don't have that information. Someone has it, but not you.
Correct. The only two people who are, even for the trial that we carried out and finished with Leukine, which actually showed a benefit in people with Alzheimer's disease in the very short 3-week trial that we carried out, the only people who are unblinded, even though the trial is over, we're still analyzing some of the data, are the pharmacy that actually made the syringes, and the statistician, of course, who has to know who got what. All the
And
rest of
presumably those people don't know the names. They know these patients as a number.
correct. Yes.
So there's sort of these firewalls that are built. Yeah.
And that's for very good scientific reasons and very good ethical reasons.
So go back to agitation for just a moment and this new possible combination of drugs. Steve Lewis was asking, do we know what causes the agitation of Alzheimer's disease? It is such a prevalent feature that, the paranoia, the sense that someone's in the room or someone's taking things from you. Well, do we have an idea of what are, I'm guessing it's multifactorial, but what do you think is involved in the agitation associated with Alzheimer's disease?
It's not known. The psychiatrist would say that it is partly the uncertainty of their surroundings.
Mm-hmm.
Their memory and their executive and cognitive functions are so damaged that they are in a world that they don't understand, that they don't recognize their loved ones, they don't recognize their physician, they don't know where they are. That would be scary for anybody with normal cognition. But when you have a cognitive problem, that would be even scarier. And agitation is a pretty common response to that kind of uncertainty. That's overly simplified. It is, as you said, multifactorial. And that's why this new combination was probably designed, because they saw some effect on some aspects of neural networks with one drug and a completely different set of effects with a different drug. So why don't we try them together and see what happens?
Yeah. There's a good ethics question here, and which means it's going to ask for your opinion more so than data. But for people who are desperately seeking something, is there a right to try things that seem promising, maybe don't even seem promising, but they're willing to try anything? To what extent, are we as a medical community being paternalistic in preventing people from just trying whatever they'd like?
Well, there are two aspects to that question. One is what you've termed the right to try, which has come up in a number of situations in which a drug is still in clinical trials for a certain indication. The data are not yet released, or some preliminary data are released that look promising. And then it is for a very serious acute disorder. And so then a patient and a family member and their physician may say, we'll go to the pharmaceutical company and say, look, this is a crisis. We want to try this drug, not just off label, because it hasn't even been FDA approved for anything.
No labeling.
But outside of the trial in this crisis situation. And there's a lot of discussion about whether that should be allowed in greater numbers than it is now, et cetera, et cetera. The other part of your question is, suppose you hear somebody tell you on the internet that broccoli cures Alzheimer's disease. Well, the first thing to do is get hold of your physician and your scientist and say, are there any data to suggest that this is true? I can promise you broccoli does not cure Alzheimer's disease. But
it's good for you.
It's definitely good for you. And
I don't.
Whole other question.
The audience
Right.
with the impression that we're beating on broccoli.
No, I eat broccoli on a regular basis. But it's a difficult problem, as you presented and are now experiencing, when there really isn't a good treatment available. You begin to grasp at straws or even logs in the hopes of staying afloat. And sometimes that leads people down rabbit holes that are dangerous, in the sense that there are people on the internet promoting all kinds of weird things that may actually be disadvantageous, shall we say. Sometimes the data are published, sometimes the data are not published, or they're only partially published, which in some ways is worse. So my recommendation is don't believe most of what you hear on the internet, and talk to your physician. We do know many things that can help people with dementia. And that's because not all dementia is Alzheimer's disease. There's vascular dementia, which can be treated or at least slowed greatly by addressing the vascular problems, lowering the blood pressure, cutting the cholesterol, getting more exercise, getting more exercise, getting more exercise. Then, that can be very beneficial, and takes work. But the data are very good that exercise and a change in diet and lifestyle can be beneficial, not just for the heart, but also for the brain, whether you have Alzheimer's disease or pre-Alzheimer's disease. But then there are other kinds of dementia that may be caused by a vitamin deficiency. It may be caused by an interaction between two of your perfectly reasonable FDA-approved drugs that have an interaction that is bad for the brain. You need for going off the deep end and trying something weird.
Yeah. Also, just as a side note on the right to try issue, Colorado was the first state to have right to try legislation on a state level. And there is now federal legislation on this right to try idea, but it's exactly as you described. It offers you the right to try things that are already in the clinical pipeline that are being tested in a clinical trial and not yet labeled by the FDA, so not yet approved. And what it does not offer you is the obligation of the drug company to give you their drug. And so it's been extremely little used. Virtually no one has received drugs as a result of the right to try bill that they would have been unable to receive otherwise, because when things are in a clinical trial, there are reasons why the drug company may not want to just willy-nilly hand out that drug to people who come knocking and saying, I don't want to be in a clinical trial, or I can't be in a clinical trial, but please let me have some of your drug. So it's been a complicated policy issue that is attuned to the idea in this question of, look, why shouldn't people just be able to try something? But it's not as easy as that initially sounds.
That's exactly right. And you can imagine the sort of extreme situation where a drug is in clinical trials. It is looking good if they have an interim analysis, or they don't know yet. And we're going to look into the future. We're going to say, this drug is actually a really great drug for condition X. Okay, but it's still not known yet. And then somebody wants to try it, as you say, under a right to try law. And the pharmaceutical company says, look, if we give you this drug and you don't fit our inclusion and exclusion criteria for the trial, this drug might actually have a bad effect in you where it wouldn't have a bad effect in the majority of people. What happens when you take this drug and die the next day? It will be immediately in the press. It will immediately damage the potential reputation of this drug. It could even lead to pressure to halt the trial. And then the potential benefit of the drug is thrown out the window. So it's really potentially dangerous to the public to not finish the clinical trial properly before you mess around with giving the drug, as you say, willy-nilly. Now, of course, if somebody is dying right now, and the drug has a potential, just a potential for saving their life, it would be potentially unethical to deny it. But it is complicated depending upon what the situation is, the patient, the indication, the cost of the drug, the difficulty of prescribing it, the dosing, it all gets very complicated.
Yeah. And as you say, the folks, it doesn't help the situation that the folks who may be most eager to get a drug through a right to try appeal are the people who are at the end of their rope and who probably are going to die in the near term. And so, the likelihood is you're going to give them the drug and they're still going to die. And then
Yes.
the death may be attributed to the drug, or maybe they'll die faster, maybe they'll die slower, but these are people at the end of the line. And so it's, I think, not to be cynical, but the drug company does not have a lot of incentive to let people use the drug who, are probably not going to do well with or without the drug.
That's a very wise insight, and it is relevant to the lecanemab trial, in which people have recently been described as dying during the trial. Now, when you read the details, you find out that they had many comorbid problems. They had very serious heart disease or high blood pressure. And in these phase 3 trials, after the drug has shown good promise in the phase 2 trials, they very often increase the number of participants greatly and broaden the inclusion and exclusion criteria to more reflect the general population. Because, of course, people over 65 or 70 who have Alzheimer's disease, many of them also have something else. And so they didn't want to exclude those from the phase 3 trial, as they did in the previous trial. So then the statistics have to be brought in as to say, we're going to expect a couple of people to die. They're old, they're sick. It doesn't necessarily mean it's from the drug. And so that will be a very difficult calculation to make from the data as to whether it's more or less likely due to the drug.
We've got a ton of questions here, so I'm going to have to start sort of picking and choosing. And I want to continue a little bit on this amyloid hypothesis and the angiopathy, because the other thing that has come up recently is the idea of treatment-associated brain shrinkage, and that the shrinkage may be greater than the volume of the amyloid being removed. And I'm wondering if you can tell us a little bit about that, and what are the kinds of questions that we ought to be asking in terms of the apparently fairly common phenomenon that people receive these drugs and the brain mass shrinks even more than you would have expected by just removing the amyloid.
That is an observation that was first made when these drugs first went into clinical trials. What happens is that the brain seems to shrink faster for a little while, and then it, shrinks at the same rate, but from a slightly lower position as people who are not taking the drug. Now, the problem with interpreting that as being bad is that we certainly know that people with Alzheimer's disease have brain shrinkage. This atrophy is characteristic in certain parts of the brain, and it definitely is linked to the loss of nerve cells. But when you treat somebody with a drug and you have a very rapid change in the brain volume, you don't really know what that's due to yet. And we still don't know, the scientists still don't know who study this. There are obviously lipids and white matter and even water contributes a great deal to the total volume of the brain. So exactly what is being reduced is still not clear, and whether it has any clinical relevance whatsoever.
I want to come to one of the questions that is asking about sort of balancing what's known and what might be possible. It's one around the back to agitation, one around the sort of pros and cons of using something like Seroquel, quetiapine, which is a drug we understand pretty well and has some significant risks along with the benefits, and use of melatonin receptor agonists like Ramelteon, which is expensive, newer, but may be better in some hypothetical ways for people with neurological impairment, including potentially Alzheimer's. How do we think about sort of the relative risks and benefits of things where those numbers are all uncertain? That's probably an unfair question, but I think that's That's kind of what this person is getting at, is like we're constantly making these balancing choices.
It's a very fair question, but it doesn't really have an answer. The reason that we study Alzheimer's disease in the laboratory in mice is because every mouse is exactly the same as best we can make them, genetically and environmentally. People are totally not the same, genetically and environmentally. And that means that every physician-patient interaction leads to decision-making that is based on incomplete knowledge. And therefore, it really behooves the couple, shall we say, to make decisions together based a little bit on trial and error. That is to say, if the standard anti-agitation drugs are not working or are giving side effects that are, too much, then trying another one and trying another one and trying this combination is valuable. And physicians and pharmacologists are faced with this all the time as to there isn't a one-size-fits-all. And since there isn't, how do you move forward in each individual case, trying to find the best single drug or combination of drugs to fit their particular symptoms?
So Peggy Badai has asked a really intriguing question to me, at least, because we've been talking a lot about clinical, a lot about treatments, drugs. And she says, from a practical perspective, the issue of sort of good days and bad days of people with dementia may be impacted by not only sort of the biology of the person living with dementia, but also by the skill set, the behaviors, the communications of the people they're living with, their caregivers. And she's wondering whether there is sort of a research agenda around training and support for the caregivers, for the care partners, on how to communicate with people living with dementia. Is there something, is there something that is happening or that ought to happen in terms of research on how to support the people who are supporting the people with Alzheimer's disease to avoid things like paranoia, agitation, or to mitigate sort of the, de-escalation training for that?
There definitely is de-escalation training. There is definitely caregiver training. It's available through the Alzheimer's Association, and there are other groups around the country that essentially try to make the situation, the condition of the patient with Alzheimer's disease as supportive as possible. And there are very many sort of rules of thumb. Don't argue, distract, calm, and these take skill sets that need to be learned. And the family is very good at that if they follow the help from the experts. Unfortunately, nursing homes don't have the staff to be able to have as much one-on-one attention as would be most beneficial. But even they have training how to deal with agitation and depression, et cetera. It's a very complex disease, and it's a goal of everyone, including the patient, but certainly their family and their other caregivers to try to deal with it in ways that work for that patient.
Yeah, we're coming up on the end here, but I want to close with a couple of straight-on ethics questions. There are people who have Alzheimer's disease and do not acknowledge that. And those people may benefit from either a drug or being in a clinical trial. And yet getting them into a clinical trial might involve some level of cajoling. And that's a kind word, I suppose, for something akin to a coercion or misleading, or right. And I'm just wondering if have you run into that in the context of enrolling people in clinical trials, that you find the family is sort of trying to get the person to sign on to a clinical trial, but they're not telling them the full story because they think the full story would entail telling them they have Alzheimer's disease, and they've already said they're not going to believe that. And sort of, how do you navigate that?
In clinical trials, it's fairly simple. We have to be totally transparent. There's no cajoling, there's no fooling, there's no getting around their resistance. They have to know exactly what they're getting into and do it completely voluntarily. And of course, they don't know, as the researchers don't know, whether they're going to get intervention that is experimental or they're going to get a placebo. But the situation that you're bringing up is more relevant than to getting people into analysis and potential treatment with the already available drugs. If they're not willing to admit that they have a memory problem, which is not at all uncommon, then it's a matter of education and slowly moving them into the realization that if they have a memory problem, it's not something to be embarrassed about. It's not something that's their fault. And it may even be something that's treatable. The assumption that Alzheimer's disease is not treatable is not entirely correct. But as I said, there are other dementias that are more treatable. And so it's very foolish to take the attitude that age comes with challenges. Memory problems is a normal part of aging, and we're just not going to bother grandma about this. That's counterproductive. Memory problems are not always, at least to a high degree, associated with aging. That is to say, aging is associated with memory problems, but there are memory problems that are outside the normal realm of aging, and they require clinical experts to assess and to potentially treat.
And then last question. I want to talk about genetic predictors. You mentioned ApoE4, which I always think of as being the one that predicts both heart disease and Alzheimer's. And if you're checking for one, you're going to learn about the other, whether you liked it or not. And I'm wondering how that is being addressed these days in the genetic testing arena, because early on, there were challenges where people got information that they really would not have wanted because there are people who don't want to know about Alzheimer's disease. I think more so than people who would say, don't tell me if I'm at risk for heart disease. But insofar as Alzheimer's, has not had historically anything you could do to really prevent it, there are quite a number of people who would say, don't tell me about that. And then they end up learning that they have a risk factor for it because they do a genetic test. Is that being more proactively handled these days in the genetic testing arena?
Well, of course, people who wish to go online and get some genetic testing are to some extent taking their future in their own hands and making their own decisions. There are coupled, genetic counseling associated with with certain kinds of information that come from that. But the individuals do, in my opinion, benefit from talking to their physician and thinking about what might come out of such genetic tests. Now, with respect to ApoE4, it is a risk factor. It's inherited. We have 2 ApoE genes, and you can have ApoE3-4 or 3-3 or 2-3. Those are the most common ones. And having an ApoE4 allele from one of your parents increases your risk about 3-fold. But it is only an increased risk. It is not a guarantee. Even if you get 2 ApoE4 genes, one from each parent, so you're double ApoE4, you're not guaranteed, although it's very high frequency, of getting Alzheimer's disease. And I don't know my ApoE4 status, and I've deliberately decided to do that because there really isn't a great deal that somebody with ApoE4 versus not ApoE4 can do. It's better to take the attitude that you do have ApoE4, and you should go out and do all the things to protect yourself from developing Alzheimer's disease that you should be doing anyway. Lots of exercise, better diet, lower your cholesterol, lower your blood pressure. Those are good for you anyway. So just pretend you're ApoE4 and go out and do what you should be doing.
And eat your broccoli. So, right. So a number of very good comments and questions, and really appreciated it. It again is the top of the hour. So I want to thank both of you, Dr. Potter and Dr. Wynia, for this. Really, really appreciate it. And to everyone, our next Ethics Grand Rounds will be January 12th, 2023. And we will have a panel in terms of who are you going to call, ethics, legal, palliative care, or employee well-being. At our center, it is the REST team, Resilience, Education, Stress team. So we will be meeting again in a month, and hope you're able to join us in between time. Again, thank you very much, and Happy New Year to everyone. We'll see you in January. Bye-bye.
Carol.